Maki. I'm one of the allergy and immunology consultants working here. I think a lot of you have already heard of me. Thank you, Dr. Aradati, for giving me the opportunity today to speak a little bit about my specialty. Um, Allergy and immunology has a very wide scope of patients that we cover, but unfortunately, it's very new in the region. So I think it's very important to kind of try and shed the light on some of the major things that we see, and hopefully, we'll be able to both like all work together to help the patients. So I'll be looking forward to collaborating with everyone. Just a little bit about myself. First of all, I'm born and raised here in Bahrain. I did my medical school in the Royal College of Surgeons in Ireland, RCSI Bahrain, just across the bridge over there. And I had the opportunity to go and do residency and fellowship in the United States. I did my residency in pediatrics for 3 years in the Brooklyn Hospital Center, American board certified pediatrician. This is me with some of my co-residents back in our pediatric clinics. And then I was very fortunate to get a fellowship post and also in New York, Montefiore Medical Center, one of the largest allergy and immunology programs in the country. We had a total of 16 allergy and immunology physicians over there. We were basically the #1 referral center for patients with severe combined immune deficiency in New York. We had patients come in and referred from all parts of New York for severe combined immune deficiency, where we diagnosed them, had bone transplanted them, and then following them after that. We also are the largest IVIG infusion center. Actually, the person who was the head and the chair of the department was one of the first people to discover pediatric HIV. So I had a good exposure there to patients with primary and secondary immunodeficiency, and we were the only center in New York in that region of the East Coast that actually did chemotherapy drug desensitization. So we had a really wide range of scope of patients, and with the 16 different physicians, we really had a lot of small subspecialties within allergy immunology. So I was fortunate to get exposure to multiple parts, and this is me with some of my colleagues working on making allergy shots. So, just like I was saying, it has a really wide scope of diseases. We support multiple subspecialties, and I'll try to highlight some of the major diseases that we see in our specialty and in the upcoming few slides. We're considered experts in biologics, immunoglobulin therapy, and in vaccination. So, whenever you're considering a patient, you want to start on a biologic, it will be great if you let me know or let us beforehand. We can do some specific testing to make sure that patients are suitable for them and find the best biologic for them. So first of all, allergy immunology. So let's start with allergy. Common is common for us, and our bread and butter is allergic rhinitis, allergic conjunctivitis, and allergic rhinoconjunctivitis. So this might be very obvious, but it's very important for us to see these patients at least once for allergy testing and possibly even treatment. Like even if you think this disease is very mild, it's at the beginning, it's important to try and identify triggers because we can actually spare them from getting things like steroids, inhaled corticosteroids. We can limit their exposure to specific allergens, and that will be more than enough. And it's a simple test that we do, and from that we can get the answers. On the other aspect, if you think the disease is really severe, we also need to see these patients. We provide allergen immunotherapy, which will I touch on like a few slides in, but it's the only disease-modifying treatment that is available for these patients. So it actually, if you have a patient with allergic rhinitis and you want to prevent them from getting asthma, this is the only treatment modality that has been proven to prevent asthma formation in these patients. And if they're allergic to only one thing, let's say they're monosensitized to dust, by giving allergen immunotherapy, you can prevent them and reduce their risk from developing other allergies. So it's one of the few treatments that actually can make an impact in these patients. So it's important that we see them at least once to assess them, and then we can decide whether to continue with us. So please, our ENT, our ophthalmology, family medicine, pediatricians, whoever you see these patients, just let us know, and we'll try and help out. Same thing with asthma. So asthma, especially if it's in the pediatric population, it's very important to assess and do allergy testing at least once. Identifying allergic triggers can reduce their exacerbation risk and their need for steroids. This is especially important if they have persistent asthma and they're on steroids. We can really limit their use. The other spectrum of asthma are patients with severe asthma. So those who require biologics, at that point also please refer them to us and we'll try and help out. On the adult spectrum, when it comes to asthma, some entities like Sturge-Strauss disease, or if you suspect aspirin exacerbated respiratory disease, we can actually provide curative treatments by doing aspirin desensitization, and maybe they won't need their asthma medication. So it's also like, please just let us collaborate and try to help them out and try to figure out if there are ways to limit their steroid exposure, or like, since these are chronic diseases, you really want to limit the amount of medication they're taking. So hopefully, if we work together, we can do that. Another big bread and butter for us is food allergy. We can help both in diagnosing these patients and providing both challenges and oral desensitizations. What I mean by that is that a lot of food allergies actually resolve as you get older, but a lot of patients are very hesitant to restart or take the food again. So it's important for us to do what we call challenges, where we give them the food in specific amount and quantities in the clinic over 1 or 2 days, and we make sure that they tolerate the food before we ask them to go and do it at home. Also, in patients who have severe allergies that are not resolved, like for example severe shellfish allergy or severe nut allergies, there are newer recommendations to try them on something called oral desensitization, where we give them small amount of that food just to make them tolerant enough to that food so they don't get severe anaphylactic reaction from it. So they might still be allergic, but they won't have a severe enough reaction that would lead to life-threatening events. So that's some of the things we can do. Next, something I'm very passionate about is drug allergy and drug delabeling specifically. This is a big move all over the world now. We know that about 90% of patients who are penicillin allergic actually resolve, their allergy resolve within 10 years. So it's important to assess these patients, make sure they're really not allergic by, again, doing skin testing, challenges, and so forth. We also provide desensitization protocols for patients who are inpatient when you want to start them on a treatment which you feel that is the most suitable for them, the most appropriate, and you're worried because they have allergies. We can do a desensitization protocol to have them tolerate that medication. Also, same thing for venom, instinct stings, latex for patients, whether it's pediatrics, healthcare worker, that's also something we can test and try to treat. In continuation of the allergic diseases, allergic skin diseases is a big part of what we see as well. Patients with eczema, contact dermatitis, or simple hives, we can do some workups for them, try to identify triggers. For example, patients with eczema, some of them even can respond to allergy and immunotherapy to dust mite. This is a new thing that have been started, and have seen that patients with severe eczema who are allergic to dust mite can actually benefit from allergy and immunotherapy. And biologics, Dupixent has made a big change in the management of patients of eczema now, and a lot of patients are like no longer need of taking their any oral, like the use of oral steroids or immunosuppressants like a cyclosporin has become very old school now. So there are other better medication with less side effects that we can provide. And on the other aspect, with our GI physicians, we can definitely help with some of the hypereosinophilic conditions like EOE, which we can work together on providing specific diets and follow-ups for them, and collaborate in helping prevent worse disease and formation of strictures and so forth. And in general, this is like the white blood cell that everyone forgets about, the eosinophils. If you do notice that your patients have elevated eosinophils, absolute eosinophilic counts more than 5,000 and 500, sorry, and definitely if it's more than 1,500, they need an evaluation. This can be a primary malignancy, which we can work up, or it can be an idiopathic hypereosinophilia, which is very common. And we do have now biologics that can treat these patients and prevent them from formation of more severe and more sinister diseases. And something that has been more and more in light now, and there are a lot of research on, is mast cell disorders. These patients tend to present with very non-specific signs. They come to you saying, oh, my body is itchy, I'm flushing, I might have some hypertensive episodes. So these patients can also be assisted by us, and treatment can range from something as simple as starting them on Montelukast to something more extensive like starting them on biologics. So that's also part of the diseases that we see. And most importantly, I left this on a slide by itself, is anaphylaxis. So any patient who presents with anaphylaxis or query anaphylaxis, please, they have to be seen by an allergist for a workup. They need an EpiPen. I know there are issues in prescribing EpiPen in the country right now, but hopefully we'll try and work on that and try to make it more available for our patients. It's really a life-threatening disease that can be easily prevented. So I hope we can work together on trying to reduce these in Bahrain. And the other aspect is immunology. I'm not going to spend a lot of time going over the warning signs and all so forth, but in general, primary immune deficiencies, if you have a patient with recurrent infections, I have a list here of some of the things that you have to keep in mind. Hopefully in the future I'll be given more lectures to try to highlight each and specific like of these diseases. But in general, if it's a recurrent infection or if even it's a single severe infection, please don't worry about calling me, texting me, just ask me about it. I will love to discuss it. Even if we don't, it's not a proper referral, like the patient doesn't need to come see me. At least if you have any doubt, just let me know and I'll be happy to help. We can really help these patients by testing them and providing appropriate treatments, whether it was prophylactic antibiotics, immunoglobulin replacement, or even in some cases, bone marrow transplantation. And immune dysregulation and secondary immune deficiency. I kind of listed here three things and three examples of when a secondary immune deficiency is important for immunologists. Whenever you're considering to start IVIG, please let us know beforehand. Whenever you're starting rituximab or infliximab, especially in a patient who have IBD and they're young, it's important to see an immunologist first. These are multiple new studies now that basically highlight the importance of this. For example, in patients with infliximab, the reason why they need to be seen by us first is because there are a lot of patients with early onset IBD that can have CGD, chronic granulomatous disease. And in this group of patients, if you start them on infliximab, they tend to have more severe symptoms. And the test is very easy. We literally just do one test for them, clear them. It's similar to what you do before you start a patient on, like do a TB test before infliximab. Now it is considered in young patients before starting infliximab, you're supposed to check for CGD. So these little things, whenever you consider them, just give us a call. We can discuss and we can see if there is anything or a nuance in the management or treatment for these patients. Same thing for early onset lupus or IBD. If your patient is young and they have very complex autoimmune diseases, I'd love to talk to them and talk to you and try to discuss a better treatment plan for them. This just summarized the different testing that we do. It just compares skin testing and serum-specific IgE. I'm not going to go into much details about it. I just put it on because whenever you want your patient to have a skin test, and you want to refer them, just please make sure to tell them to not take any oral antihistamines for the last 5 days, at least before seeing me, just to have the test being done more accurate and the patient doesn't have to come and go and have multiple visits for no good reason. And finally, allergen immunotherapy. This is what we discussed early on. The general concept is that you're giving that specific allergen in a very small amount and increase it over time. So you start at a very low dose, increase it over time. That usually takes like 6 months for us to reach maintenance. And from there, then they get a shot every month for a total of 3 or 5 years. It is a commitment indeed, but like I said, it has a lot of advantages for the patients. Now we have something called sublingual immunotherapy, which has better compliance, which means that the patient don't really have to come even for the hospital to get a shot. If they're worried about shots, they can get the medication under the tongue and they can do it at home. So we have options even for patients who are worried about shots and commitment for a longer period of time. There are ways to increase their compliance. And this is just some sublingual immunotherapy that are approved currently. And I know that some of them are available in the region. I know that in Saudi and the UAE, they're already using them. And I know there are some patients in Bahrain who are already taking them. So hopefully we can provide them for our patients here as well. And this is just a list of the major biologics that we deal with and we use for multiple treatments. And yeah, that's all I have to say about this today. Thank you so much. It's really all about teamwork, and I truly believe that we have to put the pieces of the puzzle together to try and help our patients. And I had the really big privilege of working with all the listed subspecialties on the left over here, from pediatricians to OBGYN, rheumatologists, pulmonologists, dermatologists, ENT. And I would love to do the same here in the hospital, and hopefully we can collaborate to do better for our patients. Thank you so much. I'm a text away. This is all my information, my phone number, my WhatsApp number, my email. My clinic is at the pediatric section on the ground floor. Please feel free to come by, chat, and we can always discuss patients and discuss life and anything you guys want. That's it. Thank you so much.
Thank you very much. Just have one question.
Yes, go ahead.
There is a practice that anybody who is going to be started on IV or IM antibiotics does. It's
Yes.
and I don't understand.
Yeah.
Just to do
To do the testing dose. this is not recommended anymore. We don't need to do testing doses for patients unless they do have history of allergies to specific antibiotics. And in that case, we don't really do a testing dose. It's better to do a skin test than anything, or try to find an alternative. The best way to do it is usually a majority of the patients just challenge them and they'll be fine. The majority, especially of antibiotic reactions in children, or curie and antibiotic allergies in children, are really just like a reaction to a previous viral infection or not really allergic. So we don't recommend doing test dose.
Something that needs to be sort of reminded to everybody.
Yes,
Thank
correct.
you very much. Any
Thank you.
question?
Yes, go ahead.
Very nice presentation.
Of course.
I have one question related to what sir already asked. How to, know that a patient is going to be allergic to certain oral antibiotics?
To oral antibiotics. You really can't predict who's going to get allergies. There are studies that have shown that patients who already have a drug allergy to another drug are more likely to develop allergies to others, even from different classes, not related to the same class. We're not sure why people develop allergies in general. We definitely think it's a combination of both genetic and environmental changes. Family history does play a role, but it's not enough of an indicator to avoid medication. Like we hear this a lot. Like a parent would come and say, "Oh, his siblings had a history of penicillin allergy, so I think he might have penicillin allergy." But we don't take it for like it's not even an indication for testing at this point. Include not only drug but also food allergies. Like it used to be said that patients who had peanut allergies or a sibling with a peanut allergy would have a higher risk of getting peanut allergy themselves. But it's been shown that the risk is very, very slight. It's like 3% risk in comparison to a population, to the general population, which is a 1% risk of getting peanut allergy. So again, even that is not an indication for testing. However, we'll always be happy to talk and discuss it and talk it through. And if parents are really, really worried, it's very easy to do a skin test for these things to confirm it or deny it. Yeah. And this brings actually a good point about patients. And I kind of skipped over it. Vaccines and vaccines hesitancy has been a big thing nowadays, and people are always worried about a reaction, especially to the COVID-19 vaccine. So it's important to sit down with these patients and try to counsel them. And there are available testing for them as well.
Thank you very much.
You're very
I'm sure that there will be lots of chances to talk with you.
Yeah, of course. I'm around whenever you guys. Yes,
Thank
please.
you.
Thank you. Thank you, everyone. Have a good day.